Okay. Good morning. My name is Janet Parks, and I'm the president of the League of Women Voters of Bowling Green. And I am so happy to see all of you here this morning. To tell you the truth, we're just a little worried when it got a little bit later and didn't have a big crowd, and now we have a great crowd. So we're really happy about that. I've been asked to make a couple of announcements at the end of the program, and I've decided that given my memory, I'm going to make them now. Because and if I remember them at the end, we'll do it again. But the host committee has asked that when you're finished after this meeting, that you carry your cups back where? Who told me? Right over here. Okay. And self-bus your tables, if you would, please. The other announcement is at the end, if you would, please, I'll put a bag over there by the door to collect name tags. We do recycle our name tags, so I would appreciate that. If I say it again, then I'll just say it again, because maybe some people also have forgotten. Jim, we are so happy that you're here today to give us a Saturday morning to tell us about this fabulous new facility that we have. We're really interested in hearing about it. We appreciate your coming. But before moving to that part, I did want to briefly share some information about the League of Women's position in regard to mental health services. Sometimes people wonder, what's the League of Women? They're about voting. Why are they interested in mental health? And I'd like to explain a little bit about that. Since its founding in 1920, the League of Women Voters has advocated for governmental and social reform. So we've always been interested in reform, and our standard practice regarding issues is that we study them from a variety of perspectives. After we've studied them, we get consensus, and then we take a position on those issues. So the position that we have about mental health is that every U.S. resident should have access to a basic level of care that includes the prevention of disease, health promotion and education, primary care, including prenatal and reproductive health, acute care, long-term care, and mental care. And as a local league, we're committed to the continuing availability of mental health and substance abuse and addiction services for all. We also support sufficient funding of mental health services and acknowledge the increasing influence of addictions on the mental health of our residents. And I think you might have noticed that whenever there's a mental health levy on the ballot, the League of Women Voters writes a letter to the editor and supports the levies for mental health. And the creation of the Crisis Stabilization Unit is totally congruent with our position on mental health. So we're really happy to have you here, and we're looking forward to your remarks. And at this time, I'll turn this over to Shar Sher, who is the chair of our mental health committee.
Hopefully it works. Yes?
No.
Okay, good. Well, I want to start out by thanking a few people. We had some lovely refreshments today, and that's thanks to Flo Klovenstein and Ellen Scholl and Laura Schutz. So also want to thank Nat Hoffman, who is recording this on Zoom for us. And we'll later be able to put this on YouTube. So we share it on our YouTube channel in the league. And then I want to introduce my very dedicated committee, because without them, this would not have happened. If I had to do this by myself, it definitely would be better. So anyway, Lindsay Jo Durham, Fisheries, Paul Haas, Jennifer Lampy, Barbara Murphy, I don't think is here today, Katie Harris, Jane Robb, and Laura Schutz. Anyway, we're just very, very glad you're all here. And as Janet told you, our local league does have this position statement, And part of what it says is that we support the continuing availability of mental health and substance abuse addiction services for all. We also support sufficient funding, very important, of course, of mental health services, acknowledging the increasing influence of substance abuse addictions on an individual's mental health. So these two unfortunately go so hand in hand. Our committee meets monthly, and in order to keep current on Wood County mental health services, we often meet with leaders of various agencies to learn what they're emphasizing and what needs they have. When police responses to mental health crises were making headlines in the national news, we wondered how Bowling Green was handling such crises. So we met with the Bowling Green Police Chief, Tony Hetrick, the BGSU Campus Police Chief, Mike Campbell, and Sheriff Mark Vasilishin. We asked them how they dealt with crisis calls, and in particular, mental health crisis calls. Now, we were very pleased to find that all three worked with mental health professionals on a regular basis, and many on some of these calls. And often mental health professionals are present on the scene. We also found out that one of the greatest needs was a freestanding community crisis center with beds for overnight or short-term housing of a person in crisis. All the Toledo hospitals are usually full. Wood County Hospital doesn't have a mental health facility per se. And so patients in crisis were ending up in jail. Not something anybody thought was the right place, but the only place available. Later, we were heartened to hear about this new crisis stabilization unit and that it was being planned and would open late in 2022. A ribbon cutting was held in late October, and our speaker today, Jen Emahiser, is going to tell us a lot more about this facility. Lindsay Jo Durham from the committee will be introducing Jen.
Hello, my name is Lindsay Jo Durham. As someone that faces mental health challenges myself, I'm very much looking forward to what Jen has to teach us today. Jennifer received her bachelor's degree in social work from the University of Toledo and her master of social work from Eastern Michigan University. Jennifer is a licensed independent social worker with a supervisory endorsement in the state of Ohio. With over 25 years experience in the mental health field, including a variety of roles in community mental health, including case manager, individual and group therapist, program manager, and clinical director. Jennifer is passionate about creating hope and improving the lives of others. She currently serves as Director of Services in Wood County for Unison Health. Please join me in welcoming Jennifer.
Good morning, everyone. First of all, thank you for having me, and thank you to the League of Women Voters for your continued interest and investment in mental health. It's a topic very passionate to me, and as you heard, I've spent my life working in that arena. So again, thank you. I appreciate the opportunity to come talk about what we do, and anytime anyone will let me. So as Lindsay said, well, a couple of things. Technology didn't work out, so I have my stuff here, and I'll kind of wing it a little bit. I want to share what all about the unit, kind of a little bit about how we got to the unit, and then where we're at, because we're kind of in the beginning stages of its opening, and there's more services that will eventually be there. But just to give you I am a long time in community mental health, newer to Wood County. Just so you know, I've been in and out of Unison for all of those 25 years, just about. But I came to Wood County as the director for Unison in January of last year. So I just want to touch on the existing crisis services that we had, and then the expansion of that, if that's okay with everyone. Like I said, and you'll get the PowerPoint that we planned to share. But it's really the video that's kind of cool that talks about the center and shows a little bit of the center, so you get to see what it looks like. But so anyway, in 2018, late 2018 is when Unison started to provide the mobile crisis services. as I was explaining, there are no psychiatric inpatient beds here in Wood County. And that is still currently, there are no psychiatric inpatient beds. So when someone needs a hospitalization, they have to go to Lucas County, or we offer a coping center in Wasion, or Full Care, or even Blanchard Valley as a small unit in Finley. So in that, there's been historically folks in a psychiatric emergency would go to the jail, be arrested, or go on to Wood County Hospital, or then we would try to find placement. And again, for anyone in the county, it had to be an out of county placement. So thus the thought for the crisis stabilization unit. The mobile crisis, we back up for a second, began that continuum of care. So from end of 2018 until we opened the center, our crisis team is on call 24/7, 24 hours a day, 7 days a week, with a licensed clinician that responds in the community, as we were talking about. We have a protocol, which is a facility in Texas, mans our phones. So it is always answered by a licensed clinician if the community calls into our helpline, which again, we have the information back there if you'd like to pick that up. So that's 502-4673, 502-HOPE. You can call that any time of the day and you will get a licensed clinician. From there, they will potentially dispatch us for the police. And then the police, the hospital, our community partners like the nursing homes, the urgent cares, any facility in Wood County has our direct line to reach our staff that's on call. So that's another, so they can reach us directly. So if police get called out to a home, it's a mental health emergency, they get a hold of our on-call person and we respond within an hour on scene. So we do a pre-screen, we facilitate whatever those needs might be. So that's kind of the first step of our crisis team. And again, we were, as that's been moving and working and providing care. And on average, we do about anywhere from 60 to 80 pre-screens per month. This particular year, we are unfortunately trying to break some records. In already in April, so today's the 15th, we have done 53 pre-screens in Wood County alone. So that's quite a bit. And for the quarter, I think I got the data yesterday, it was like 296 for January, February, March. So we're approaching about 100 pre-screens per month. So again, and then on average, about 50% of those end up in hospitalization versus like a crisis plan or linkage to other services. So all of that being said, we needed a place in our community for folks to go that needed hospitalization. So I'm sharing a little bit of that because I came kind of late to the party as far as I've been doing this work for a long time, but later to Wood County. So the Wood County Mental Health Board, the community providers, our vice president and CEO were very much involved in trying to birth the unit because there's about 700 CSUs in the country. There's about a handful in Ohio. So, and part of that, just to give you that background, is funding. Right? There's currently not per diem codes and things that we can use to fund inpatient at this level of care. It's either inpatient or outpatient codes. So with the help of the board and the amazing community that Wood County is, they are funding a big part of this through levy dollars and different resources, because without them, we wouldn't be able to provide this level of care. I kind of want to give you a little background on that. So the unit in and of itself, which opened January 9th, it was supposed to open in late fall. It was supposed to open in the summer, I think, initially, and then late fall, and then, construction issues and different things. So we opened January 9th. Make sure I give you highlights here. We opened January 9th, and what we are still kind of considering a soft opening. So we currently have 6 beds available. From January till now, we've had approximately 45 admissions. We have had about 25% of those were BGSU students. And so it's all voluntary. So that is one of the difference between what we would have to offer in like the inpatient facilities in Lucas County or those outlying areas. It's voluntary, which only basically means you have to be willing to sign yourself in. Doesn't mean that you can't be acutely not well, but as long as we can manage you safely, you can come there. And as long as you're willing to sign yourself in. So So the average stay is about 3 to 7 days is what we're hoping, up to 14 days, depending on what is needed. We've had a couple people stay a little shorter, and we've had a couple people stay quite a bit longer. And they're, so kind of when, and as we're currently operating, all of the admissions are coming through our mobile crisis team. So that is how we are kind of, like we said, with soft launching, they are kind of a gatekeeper right now. So for the community providers that we work with on a pretty regular basis, they know if they feel like somebody's an appropriate admission for the unit, they get a hold of mobile crisis. And from there, our mobile crisis team, again, responds 100% within an hour, about 75% of the time within a half an hour. So then we're on site, we do an assessment, and if we believe that they're a good candidate for the CSU and they are willing to do that, we start that process. I was gonna say, if you have questions, please.
Yes, could you define the we, who refer to, who are the we?
At Unison, the Unison staff, so we are, our mobile crisis team is made up of 2 licensed clinicians that are health officers, a crisis navigator, and then a hospital liaison that works within our team. But when I speak of we, it's the Unison mental health team. And on the unit, it is staffed with, we have nursing 24 hours a day, 7 days a week. We have licensed therapists 24 hours, 7 days a week. And then we have mental health techs about 2/3 of the time that are on staff. So we being the Unison team, but we serve anyone in Wood County. You do not have to be a Unison client. You don't have to be connected with community mental health. Just anyone in our community can access those services. Does that answer? I want to make sure. Okay. Can you, well, more, do you want to know who the, like, exactly their roles or how they help?
You're saying there is a team. What's the central board?
On who does the admission?
Who coordinates it all?
Ultimately, it falls on like myself as the director, and then we have, as far as admission process, there is a nurse practitioner that's on call for us 24/7, psychiatric nurse practitioner. So they would also coordinate, like they would make that decision on admission. When it comes to like if mobile crisis goes out, and it's kind of a collaboration with whoever we're in the community working with at that point. So if, I guess I can do better with examples if that's helpful. So if we're out on scene with police officers, we as mental health clinicians, we make that decision from our assessment and the information that the police give us if we think that they need hospitalization or if they can remain safely in the community. Any of our staff, if there's question, they consult with myself as a supervisor or any of our other team that do that. And then what happens in the state of Ohio, I don't want to bore you guys with details, but in the state of Ohio, if you believe somebody needs hospitalized, there's an involuntary commitment process, which is a pink slip. So if we are concerned about safety, we complete that pink slip, and then that basically states that someone needs evaluated by a psychiatrist within 24 hours. So ultimately, it's the therapists, it's the licensed clinicians and the health officers that really do make that decision. What is the best interest in the client's choice, obviously. So in our case, if somebody's voluntary to the CSU, that is their own, they make that decision. We are always looking at clients' rights and what they would like to do, other than if we feel back to they are so impaired, or their illness is creating a situation where they are not safe, or the community is not safe, then we would initiate that process of involuntary admission. That helps clarify. But it's kind of, it's a group effort. And when it comes to who's admitted to the unit, again, as of now, our mobile crisis, or even the police will call us and they'll say, hey, we're on scene with somebody who's not doing well. Would you come out and do an assessment? And then we talk to the person, we would make that, we would talk with them, see if we think that's best, and then we would talk to the prescriber who would do the admitting order to the unit. So that clarifies. But it's anything that we do is in collaboration with whatever community providers we're working with, within our own team, the client themselves, again, and then often we do a lot of admissions from Wood County Hospital now, because historically, mobile crisis would get called to Wood County Hospital, we would do an assessment. We would then potentially find that, where we would find that person a bed if they needed inpatient admission. We would find them a bed in Lucas County. But now we are finding probably about half the time we're able to bring those folks from Wood County Hospital over to the CSU for admission because they're voluntary and we believe we keep them safe on the unit. So that's kind of how that process is going as well.
How much of the need are you looking?
We, right now, a good portion of the voluntary admissions we've been able to accept. So probably about, when we look at statistics from our mobile crisis team, so say we have 100 people in a month, because that's about, on average, now again, it varies. Right now, the acuity this particular month is a little higher, but of 100 admissions or 100 pre-screens, probably about 60% of those on average, or 60, would be a crisis plan. So, and what we have in our mobile crisis is that we send them home with a crisis plan. We also have a crisis navigator that then follows up with that client, gets them connected with potentially ongoing services, that type of thing. About 40% result in hospitalization. And then statistically now, about 30 of those 40% that would, or 30 of those 40 would be appropriate for the CSU. So again, that's a higher number than we're, but that's, so probably, if you look at, it's about 80 to 90% of the people who need inpatient are more appropriate for the appropriate for the CSU and wouldn't have to go on to Toledo into one of the inpatient units. So it's.
Is there any information available about how this has affected them at the jail? They had quite a problem there a couple of years ago, I know, with so many people in severe crises and no place to put them in jail. How is this helping?
So the CSU, I have a specific really cool story I'll share for one particular person and then in general. Our mobile crisis team does do the assessments at the jail, and currently part of our board project for this year is our nurse practitioner is seeing folks through telehealth at the jail to get them on medications almost immediately versus having to wait. So that's been really cool. We're working on expanding our services. So one of the cool stories that has even just happened since we opened the CSU is there was a woman acutely ill at the jail who was charged with an offense, but is a product of DV. So was kind of domestic violence. Okay. So it was a self-defense situation, and she was arrested. So long story short, we were able to, and she was acutely not well. She was banging her head on the jail cell, threatening suicide. It was really sad. And simultaneously, the doctor at the jail has been on medical leave. So there has been some delay in folks getting medications at the jail. And the wait list for the psychiatric hospital for NOPH, which is Northwest Ohio Psychiatric Hospital, where anyone that's under arrest or in police custody has to go there for hospitalization. They can't go to a private hospital according to private hospital rules. So there was about a 4-week wait list. So we were able to, Jen Tucker, who's our crisis coordinator on the mobile team, was able to coordinate with the jail. We did a furlough, and the judge in the probation, we did a furlough, and we were able to admit that woman to the CSU. We were able to secure her a place to go at Cocoon when she was done with treatment, depending on what happened with her criminal case. So she was there when I said we've had people, we kept her there about 50 days at the unit so that she could get treatment, stabilize, and then not have to be in jail. And circumstances are she had to go back briefly, but we were able to continue, again, because of the generosity of the board and captain at the jail willing to work with us, we were able to continue her outpatient treatment. So she's seeing someone for therapy once a week over at the jail, and she is seeing our physician. So back to your question, we hope to continue to be able to do that. Again, that's a case-by-case situation as far as bringing them to the unit, because we don't want to put other people at risk. And we obviously, we need to, that has to be pretty well thought out. But Tim, who again is our primary nurse practitioner at the unit, has been seeing folks telehealth. So there's just some weird situations where people will come in, they can't get meds, they haven't been linked. Like I said, there's that wait at the hospital. He'll go in where he'll see them telehealth and we can get them started on medications. One of the goals in addition I shared with you the unit, we have 6 beds. We hope to get to 12. I mean, that's the plan. We have capacity for 12. We also eventually hope to have an urgent care out of there, which would be another situation where folks at the jail could be brought over to see our nurse practitioner get prescribed medications. And or potentially, we've also thought about bringing people over, allowing people to come to treatment there at the facility and go back. So we're really trying to bridge that gap. That is a huge area of focus for the mental health board and then our agency. Even in our proposal for this year is for us to be able to do competency restoration with folks to expedite. Because what happens too is a lot, they go to jail and they sit without treatment and they sit without medications. So we're really working hard to bridge that gap. Our team, now this is not the unit, my team also is the team that provides assisted outpatient treatment, which is another through the court, and then our ACT team is a sort of community treatment. So we really try to focus on those folks that have a lot of needs and also have criminal justice involved. So the crisis unit is 209 West Poe. So it's for a lot of folks, they know it as a former insurance building. It's right there across the street from, like there's a U-Haul place next to us where they have U-Hauls. Yeah. So we purchased that building, I think in 2021, and then remodeled it. So yeah, and then we have our outpatient office at 1084 South. So it is secure. So folks, you have to fob in and out to get anywhere in the building. So back to the clients at the building. I know I got a little off there. I apologize. But I wanted you guys to kind of see that whole picture of care and what we do. So folks can leave. I mean, they are there voluntarily. So if somebody wants to leave, they have that ability. But then we have to assess from a clinical perspective, are they safe? So then it's kind of like we step back in and make that determination. But ultimately, even in that, clients have to be fobbed in and out. We do have currently with what we're doing, because this is voluntary, and I was saying like we've had about 25% students. So we've been making arrangements. Like we had a student, like it's finals time, right? So last week we had someone that had a final. So one of our staff accompanied them to go take their final, not into but took them on campus, allowed them to take their final, and then brought them back. So we've also had folks will come and go for medical, like appointments that maybe you don't need to go to a neurologist. It can take like 6 months to get into the neurologist. So they end up on our unit. We don't want to have them miss that appointment. So we work within our team or even their family. Again, as long as we feel like they're safe, we will coordinate to make sure that they get that ongoing care in the community. We also have early partnership with the health department. Our gal that was, I forgot Miss Piece, our gal that was over from the jail also had a dental emergency. So we were able to get her linked with the health department and they helped us out there. So we, again, we're trying on a regular basis to keep folks connected with their ongoing service providers. It's kind of unique without getting into the nitty gritty because we aren't inpatient codes wise from a billing perspective. If a client comes into us and they're a Harvard client, and they really love their therapist and they're getting treatment with us and we're adjusting their meds and they really want to talk to their Harvard therapist, we can make that happen. So it doesn't have to disrupt versus it's one of those things that with an inpatient unit, that doesn't kind of get cut off from the world, right? Which is sometimes necessary, but if we can continue to, some of the downsides of hospitalization is then you get further behind in other things. You miss work, you get, so it adds more stress, although you may have acutely needed that. So this can be a little bit of an in-between. We had a gentleman that's on our ACT team go to work. He worked over at Walgreens, so he walked over and went to work while he was on the unit. So it really has there's some really neat functions that we can do because of that. But again, if we think that somebody is at risk to harm themselves, we're gonna look at that. I tell clients because of staffing issues, I've done a lot of the admissions myself. We're always So I would, first off is client safety, staff safety, your needs, right? So I mean, we really just look at that and then we kind of go, so there's not, unlike an inpatient facility, true, where we have some flexibility in that, which I think is really very, very cool.
Do you do with people with addiction and substance use? I remember that sheriffs was really concerned about people going through withdrawal in the jail.
So we're doing a little, if somebody's in full, what we would call like ambulatory detox or complete withdrawal, we can't manage that. If they are we've had some folks like on MAT, medication assisted treatment or Suboxone, they can continue that. If they are, like we've had a couple folks that they were using regularly, but when they stopped using it, they were pretty stable medically. So that really comes into the nursing assessment. So we've had a couple situations where we've had someone and then we've helped them like just kind of regulate their symptoms. We did have a gentleman that came in, was there about 24 hours, and there's like again, the nurses do an assessment, like an ASAM, drug and alcohol level of care. And he was okay for the unit, but was really having a hard time. So we got him into our recovery house. We also have there's New Vision at the Wood County Hospital that has detox beds. We haven't had anybody go there yet, but that would be the plan. So some mild withdrawal symptoms we can manage. If it gets anything above, then we look at detox. And again, another long-term service that we hope to have. And when you get the slide, you'll see this in here. Oh, I'll stop. Yes.
I know at our previous meeting, you had mentioned in addition to the beds having like 24 or 48-hour chairs. Could you talk about that a little bit?
So what we have right now is 6 beds for the mobile crisis. That's where we're at the moment. Long-term goal is we'll have 12 beds that are inpatient. As Lindsay was saying, we will have 4 23-hour observation beds. What they really are recliners. And what that entails is somebody comes in, they're maybe a little intoxicated, college kids, we see a lot of kids in the ER who maybe have edible or they're under the influence of something, but they're still medically stable, but they're under the influence. They're not, they're kind of in that gray area. We as mental health professionals shouldn't assess them until they're like under the legal limit of alcohol. So this 23-hour observation bed is like, we can keep you safe. We're going to monitor you medically. We're going to check in on you. And then we have that 23-hour period to determine what we think is in your best interest. Not only just substance abuse, we also have some folks, we have some people we've already seen like 3 times in the unit. They've been, and they will like, I had a fight with my roommate. I'm just really angry. So it's kind of a place they can cool off, give them a couple hours, and then we can, instead of jumping to hospitalization or jumping to admission, gives us a little time to see what's going on with them and then determine what level of care is needed from them. So that is a service that will open. We also will have police drop-off. So we have the police officers in Wood County will have fobs to our back door, and we have a room set up. If you look at the SAMHSA guidelines and the continuum of care in crisis, one of the goals is to have a 10-minute warm handoff with police officers. So that will be a plan. We've had a couple of those happen. Honestly, we've had situations where our mobile crisis team was out super busy and another call came in, so we've asked the police to bring them over. So if you do hear that out about the community, we are doing it very like on a limited basis, where we're just not at the staffing level, but kind of open, wide open. But so the police drop them off within 10 minutes, they go ahead and go, and then we take that client. And at that point, when that part of the unit is open, we have that 23 hours to determine, or we can assess them right away. It just kind of depends. The other component will be in urgent care, which is where, again, folks can, so a psych urgent care, where they can come in and see a nurse practitioner or a psychiatrist, hopefully within 24 to 48 hours, so they can get on meds. Again, examples help me to conceptualize things. So like I've been on a couple pre-screens myself. I'll use the students, like in the fall, they were, I was on a medication, I came to school, I didn't follow through, I didn't get my refill. I'm really having a lot of symptoms. I don't know that I'm not, maybe I'm suicidal. I don't want to go in the hospital. So, right, current practice before, you had to go inpatient, or you had to find a PCP that could get you a medication. The urgent care is a great stopgap for that, so that people can get started on medications. Again, not always appropriate, but again, that'll be another option so that they don't. We've had some people, and that's really what has brought them to us. It's like, I know this med helps me. I can't get into a psychiatrist for a couple months. My family doc won't prescribe it. They've done a couple days in the CSU and they've gotten started on medications. So that's kind of that whole continuum of care. We also, again, this exists with our mobile crisis team. And I mentioned we have a crisis navigator, and we're kind of following that same model with the CSU. So if you come to the CSU, you stay, we're going to follow you for 30 to 60 days to make sure you got connected with ongoing services, wherever that may be. That could be Harper's F for Ohio Guidestone, a private practice. It doesn't have to be Unison in any way, shape, or form. We just want to make sure that you're getting what you need when you follow up. Again, the board through Mobile Crisis had funded that program, and we're kind of working on expanding it because the volume is higher now. So again, the ultimate goal is we get you stabilized or help start that process, and then we get you going in the community. I think, because I was jumping around, I didn't speak to what we do. Oh, go ahead.
When you say urgent care, this would be just psychiatric and mental health urgent care, and not include, it wouldn't just be an urgent care place to go for.
No, yeah, just psychiatric. That's another, like, one of the models in the country when they look at best practice, it's to have a psych urgent care. Lucas County Rescue used to have one in Lucas County, which when I was in the private practice setting for a few years, I used it. It was great. Then it closed. I think Zeph has one back open in Lucas County, but it is a great stopgap for people. And it's so again, it's usually, and it's maybe not somebody, again, like if they're needing that level of care of hospitalization, but it's like, I just need to get back on my meds, or I missed an appointment. It is a way to kind of bridge that gap. They'll give you enough medication until you can get connected. We do have a partnership with Genoa Pharmacy as well. So we have, they kind of fill our scripts right away for us.
It's just a situation where a person who knows that they are having a crisis could get in touch with somebody outside of law enforcement before their situation escalates to something where the police.
Absolutely. So a couple different, right now, our mobile crisis line, we do that. Sometimes folks call any of our offices and they say, hey, we need the unit. As we continue to open the door, we will also take walk-ins. When I was talking about the police drop-in, we've had a couple of walk-ins too. We haven't turned anyone away. Like, we've had people show up and go, hey, I saw you on the news. We've gone ahead and assessed them. But my first line would always be called the Hope Line, because that which again is open to all, or 988. I just met with the folks that run that to make sure they have direct access to us. So if anybody in Wood County calls that Hope Line or calls 988, the 988 provider in our area is out of Lima. They have our direct line. So if anybody calls either of those and they know they're in Wood County and they want to get help, they should be able to get connected to us. But or call one of our offices. I'm jumping around. I didn't tell you when they're on the unit. I should say that when we decide somebody's going to get admitted, it's great. Lately, it's been within 12 hours. Tim is amazing. We get you seen by a psychiatrist. So you come in, we meet with you. We have you see a psychiatrist within that first 12 hours, and then we have you meet with a therapist, do a treatment plan, and then you're starting services. We are doing what's called a group, like partial hospitalization, so we're doing about 2.5 to 3 hours a group a day, and then individual, and then nursing assessments. So that is the treatment side of, and also case management, or kind of that. Like I said, there's the techs do a lot of case management and help lead with programming. We are a private not-for-profit, so we are funded by a mix. We do accept private insurance, but we're a 503C. Is that what we fall under? So, and honestly, I can't, again, I worked in Lucas County for about 20 years. I cannot speak to enough how much this community supports and allows some of these services, because again, in community, mental health, there's like, this program is amazing and it's evidence-based and it's all these things and then nobody wants to fund it. I understand that because it's expensive. The board does here. They really, we have a board of directors. Yeah, we just have a board who runs it and then our CEO. So it's really, I don't, I'm trying, that very bill, save me. Yeah, Unison Health. Not yet. And we actually also, so we have a lot of grant funding now. When our new CEO came in 2016, really big, along with the board, there's a lot of grant funding. And so we do already have a $500,000 committed to expansion of Post Street. I think it's so to build so we have that, we have the crisis center and out of our basement. The crisis center is where the mobile crisis team operates that I was talking about in our team. So there's a $500,000 to begin an expansion so that we can have an outpatient office behind so that people can just come to one campus and it's all right there. We do, yeah. And so it's interesting because the split in Wood County, because we currently have offices in Lucas and Wood, and then we do serve some outlying counties through Ohio Rise, which is a child program. But our split in Wood County is about 60% Medicaid, 40% private insurance versus it's more like 80-20 in Lucas County, 80% Medicaid. The other component with the crisis center as well is the Wood County board. Basically, any student who's here, they're treated as a Wood County resident. So they do GOSH funding. So those, when we pass those levies and the state and local dollars, the Wood County board's goal here in this community is everybody gets services. We're not going to let finances disrupt that. And our goal at the moment so far is that people that come to the crisis center get no bills whatsoever. They do have to pay for co-pays and medication. That's the one thing, but that's it. So what has been happening is we try to utilize insurance. We do that first. We try to build through that. And then, but there are certain services that we're offering that no matter what your insurance is, it's not paid for. Case management doesn't get covered by private insurance. So we will do those services. We will try to bill. And then what we can't get reimbursed for, then the board has been supplementing those insurance, those services. Yeah. So we are Harbor is on Prospect there. So Harbor has outpatient like we do, and then Harbor actually has DevLab, which is a women's, that's a recovery, like living for women. We are the only one here in Wood County doing the crisis stabilization. Harbor, they are looking into kids, and I know that was part of their board presentation, but right now we are the only ones doing this level of care in Wood. Zeph in Lucas County was awarded the contract through the Lucas County board, so they have a very similar situation in Lucas County that they're doing there. But yeah, there's only 5 of these kinds of facilities in the state. So we modeled, there's one in Michigan, because again, it's really tough to fund. And we're kind of, and in some ways we kind of have one foot in the inpatient world and one foot in the outpatient world. And that could change because kind of the state is behind us. When there is, it's kind of been for like a year and a half now, there is a committee at the state that is trying to work on crisis billing codes, per diem crisis billing codes, so that which wouldn't mean a whole lot of difference from the client's care perspective and what we do for them. That would just be different on our end of it and how we document and how we bill and how we do those things. It's in our, right, we're also, in my world, we're social workers or counselors. We don't want to talk about billing, but we have to be sustainable, right? And in this day and age, right, we have so much demand for care. There's not enough licensed folks to go around, so we have to try to be competitive too. We're open 24/7. That's been a learning curve for me because historically, all the work I've done, both as a clinician and leadership, was a little more traditional. Even if I worked, it was just in the evening at 7. Now we have staff around. I have 2 programs that run around the clock, so you need staff, and you can't burn them out either, right? Because this is tough work. that is why we are not at full, like we don't have the openings, although we made 2 job offers last week for therapists. So we are growing, and I have 2 people starting next week. So we are doing the best we can in the circumstance. And we have a great, like, we need people, I mean, I guess crisis work is just, it's unique, and the people that do it tend to love it, right? And I think, so we've gotten, the staff that we have are really, they're dedicated and they're great. But it's not for everyone, because you just don't ever know what you're gonna walk into. And you know, and then we have folks that love the community piece, and then other folks that don't love to be in the community, they wanna be on the unit. So, yeah, I think thankfully our CEO, again, and the board, we were trying to come up with competitive, and I know even the Wood County Board has talked about that, like really trying to incentivize. I think that comes back to as well why we haven't, I mean, we're kind of on that. I didn't even say my husband is the director of public relations at Unison. I told him to like give me a sign if there was something I wasn't allowed to say over there. But so we're right on the cusp of probably being able to expand the services. But you know, we've had some bad luck lately. Like somebody's on vacation and then somebody gets sick, and then somebody else gets sick, and when you're running crisis, then I'm out at 2 in the morning, which I don't mind once in a while. But I'm getting old. It's hard to, and you don't want to burn out. You don't want to burn folks out. So we're trying to find that balance between enough staff that you don't, because you know, not just in the time I've been there, I've been on scene with computer suicide, one of my staff was, right? Like you need a day after that kind of stuff happens, right? Like you need a moment to recover. So I guess there's a little of my like disclaimer, because I feel bad when we started talking about the unit a year ago. Oh, it'll be open. We thought for sure we'd be fully open by now, but yeah, you're just always trying to teeter on this. You know, you want to do good care, and you want to keep your staff. You know, yeah, absolutely. And I think it's unfortunate because you know even the facilities in Lucas are experiencing the same things, right? So there's not enough beds, which again is that where our hope is. You know, one of the goals in community mental health in general, right, is you always want to go at that least restrictive, you know, the lowest level of care that we provide to somebody. So really that's what's so great about the unit, the urgent care, the 24-hour observation, mobile crisis, that whole continuum is a lower level of care than inpatient. So you're hoping that you can meet the needs.
That you had some involuntary commitments. How's the process work to do that?
When we have an involuntary commitment.
Who makes the final decision?
So anyone that's a licensed health officer, like myself, we can write the pink slip, and then that is a psychiatrist is the only one, or a psychiatrist that, or a physician makes that decision if they stay. So when we can't accept pinks at the building. We've had to pink 2 people from the building. We've had to do a pink slip. I was involved in one. So we did that from our building, and then we had them transported to Lucas County for the psychiatrist, and then they make that determination. I think in those situations, both those folks were hospitalized. But when I write a pink slip, if I write it right now, it's valid for 24 hours. And according to the Ohio Revised Code, that a physician has to evaluate that person within 24 hours. And then they have that decision to either let them go or keep them. And then there's another 72-hour period the client can sign in or not. And if they won't sign in and they're still not well, that goes to court. So it's kind of and they do that through the hospitals, not as a way to force treatment. It was, you know, we're fortunate. The majority of the people that even when we have to pink slip into Lucas County, they often sign themselves in after a day or 2. So that, but once in a while, not. Eventually, you can go for. Yeah. So when that 72-hour point hits, the physician that's seeing them at the hospital can either, you know, because they can't keep them if they don't sign themselves in or if they don't have a probate order. So they really make that decision at that point. Throughout my career, I've definitely seen some where they do that. But they usually hope that they do. I think they do telehealth now, but they'll do probate at the inpatient unit. They'll do the court and they'll make that determination. And then historically, unfortunately, and it happens once in a while, forced meds, usually the only place that happens is at the state hospital. They'll do an order for forced medication. Yes, yeah. the Addiction and Mental Health.
Alcohol drug addiction and mental health services board.
I can't remember all
Yeah.
that. Yes.
I have recently written to all our legislators at local, state, national, about government regulations. And they all put all responsibility back on you guys. We support mental health. How do you feel about this?
That's it. Well, so know that whatever I say is personal, not Unison, right? So I put that disclaimer out there, right? So, it's so hard. I think, right, I'm a believer that we have rights, but I also think there's things that we can do. I mean, I think some of that, if you boil it, comes back to prevention. I will also say that what we do specifically with our involvement in folks that are suicidal or homicidal, we involve the police to take their arms. Because again, I believe people have, First Amendment rights, but I also, there are times that it's not appropriate for someone to have a firearm and that they need to be limited. So we do everything that we can in that respect. If there is a situation where we think someone's unsafe and they say they have a firearm or that they have access to firearms, that's a big part of safety planning on the clinical side, if we know that. When it comes to, in general, I've also, it was not that long ago, our gentleman was at our crisis. I didn't say that, but we do meet as a community once a week. Myself, usually BGPD, BGSUPD, Wood County Hospital, CRC, because Children's Resource Center does the kids crisis. EMS, we all meet for a community meeting once a week to talk about issues. And if we have somebody that we're concerned about, or we think there could be potential, we talk about it as a community. But we had someone present that I forget what they call them, but they talk about the risk, folks that are kind of on the radar for risk when it comes to school shootings or violent activities or stuff like that. So we have got some education on that. It's I will say too, though, that the majority of the time, it's not our mental health. Mental health folks are not violent and don't commit violence against others, right? So that is, it's some of the stuff that we've seen is pretty, I'm not getting my opinion. Some of it's been a little premeditated, so I don't think that person, they may have mental health issues, but not in the traditional, not in the sense that we're treating on a regular basis. So that's a tough one because I don't know. I think the answer is prevention and early mental health intervention. It's such a complex issue, I think, with all the violence.
Have you seen an increase in funding because of this?
Specifically because of, I know mental health, we have mental health as a whole has gotten tremendous amount of funding since COVID, I would say is probably the most. So I have said to someone, because again, during COVID, I was in the private practice setting, I was helping out a little bit at Unison, but when I came back to the community mental health world, again, working in Toledo or this area for 20 years, we've never had a SAMHSA grant. We have a SAMHSA grant, Harbor has a SAMHSA grant, Zach has a SAMHSA grant. The funding is just, it's coming. I think one of the downsides of that is we don't have enough staff to do some of the things. In some ways, there's money coming at us, but it's hard. And then, that's not always the answer, but I think it's things and this is where, my soapbox, right? Where the world hasn't caught up. SAMHSA talks about all these great services that we're doing, but there is no funding model throughout the country. Again, we only get to do this because the Wood County Board is funding us, right? In combination of other, but we get to do that because of that. If they weren't willing to do that, we wouldn't be able to do that. The insurance providers, Medicaid, those kinds of things, don't pay for the expense of these types of services.
When you use Wood County Board there, that is your unit.
No, that's the Addiction and Mental Health Services Board of Wood County. So our board runs our agency, but we have, I don't know what our contract, we have well over, I think the CSU was a $1 million contract for over that they gave So again, when we pass levies, they get some money that comes down to them, just that through the federal government and then through the state government. And then we, the community passes levies, and then they work with all of the agencies, Harbor, Ohio Guidestone, all of those agencies to fund different programs. And so the CSU and the mobile crisis team is one that they have funded for us.
Well, lots of information on the display table about Unison, about the Adamus board. Pick it up for you ladies, it'll help you understand a little bit.
And that supplements what all the things that we, you know, again, we try to bill insurance for you know, and all, but then that supplements all of the things that we do. Information, yes.
Could you just clarify a little bit? You said most of your patients are self-admitted. But then how did you get to the pink slip and say that they have to be, you know?
Sure. So sometimes we'll see somebody on scene, or we'll see somebody at the hospital, and they're like, I need help, I know that I want help. They get to the unit and they say, I changed my mind and I don't like these rules, or I don't want to do that. And sometimes we can safely plan for them to go home, but kind of as a general rule, if they have made an attempt on their life within the past 24 hours, we're going to go ahead and do a pink slip. Or if they can't safely leave us, then we make that decision. Or in homicide, like to someone else. So, and the two situations that we've had to pink slip from the unit, they were both there a few days. So the one gal just became, it wasn't as much. She needed staff one-on-one, and she was just having some behavioral issues that we couldn't do. So we had to go in and do that. The other person was harming themselves. So that's the other thing. If they tell us, yep, I'm going to come on the unit, I'm going to, I'm willing to safety plan. But then if, we actually Joint Commission is coming out next month to visit us, but we have to follow lots of rules, safety things, all of, they can't look at your risks. We have to monitor all that. But there is, if somebody wants, they have sheets in their room, if they try to make any active attempt to harm themselves, then we would go to the pink slip in involuntary hospitals.
Two quick questions. One, if someone like a practitioner in the community wanted to refer somebody, do we just call that same line, or is there a direct, if we want a direct contact with the practitioner?
Yeah, so you could call the helpline, or I can give you the direct, the 93, and that will go. That literature is chomping at the bit to go out. We have a CSU direct line that will ring. So there's one for the building that the clients can use to call family and different things, and then we have a community line that will get the direct, and so I can give you that, and that will be eventually we will get that all out to all of our partners. So so both will exist. There'll be the number to get right a hold of our mobile crisis, or you go right up to the unit, because at that point you could just send someone there with a family member, right? Yeah.
And then you were talking about the programming during the day, so that's like a partial hospitalization type of programming, and that's not going to be. That's only if someone's in the crisis unit, not like outpatient.
So we are, it's funny, one of my staff start next week. We are going to have both. So we ran, so I'll get to, yeah, so we were running, we have DBT, which I know you're a psychologist, but so certain types of therapy programs we were running outpatient as well. Our goal is to have both. We were trying to kind of combine it. It's kind of tough from the clinical because you've got folks in crisis. So our plan is to have folks in the unit attending one group, and then we're going to have our outpatients. They come to the building. That can be either in lieu of hospitalization, or a stay at the crisis center, or we see them in mobile crisis and they want to come. So we're going to offer our spare group 3 days a week is what our plan is beginning in the next couple of weeks. So yeah, and then we're going to have like a day of DBT. I have a staff returning who ran our program down in Lucas County. She starts next week, so we're excited. And then we can kind of, because when you're in a crisis setting, it's short, 3 to 7 days. You can stabilize, but there's not a lot of work on trauma and long-term issues. And then the goal, again, like we were talking, to wrap those services around, is to offer as much as we can to treat the other. So we see a lot of folks that can benefit from some intensive outpatient therapy, and we're going to offer that as well. Am I talking too long? My husband. Other questions?
I would say we plan this to end by questions answered too.
I'm a talker, sorry. I know. I'm proud of
Very
what
good
we're doing.
information.
I might have stayed a little more on track with the PowerPoint, but probably not. I'm not.
Say something about the links that we're gonna send.
Oh, yeah, we will send the links. My PowerPoint now seems so short, but it does have the basic information. It has the contact numbers, and then there is a video, a great video about our folks.
I need to say about those links. I have that in my notes to say at the end. If you send them, I can easily send the link to all the league members. There are people here who are not league members. So take one of these white pieces of paper on your table. And if you want the links, put your email address there and make sure you get it to me before you leave. And I'll add your name to the league members that they're sending her.
And we do, I still do that. So we do have, here's the crisis line that goes to the community at any point. We have some of that back there. This is a little about who's appropriate, not appropriate for the CSU. And like I said, we do have more literature on its way out that will have the direct contact information for the unit. And when we get that printed, we will make sure that you, if you want to share that, you can. You'll probably see it around too, around community places.
How are you advertising this then? What are you trying to get it out more?
Right now, I think word of mouth, but then also I'm looking to you because that'll
You
be
want me
your.
to answer that one?
Yeah, you can answer that.
So right now, because of staffing and because it's a new program within the we're really in the first 3 months of this program to work out any bugs, to make sure that we have it a well-oiled machine, right? So we're doing the soft opening, and that soft opening is a funnel from our mobile crisis or from the local, like the hospitals or the police departments. They can direct line in, but right now we're using our mobile crisis line as the funnel. As we're able to increase our staffing, increase the beds, then we'll start adding some of those other services like being able to walk in through the front door, and then we will do a lot of promotion. So that'll be on me. You'll be seeing, you might see a commercial, you might be served things. Wood County will serve social media. We'll put it probably on the radio. There'll probably be billboards, those kinds of things in the community to advertise that. But right now, Jen had alluded that nationwide, there is a shortage of counselors and social workers. And those are the folks that do the assessments. Those are our health officers. And so that makes it really, really challenging to staff a 24-hour programs. We're really kind of walking it in slow. And even without advertising, we are having people, obviously we won't turn anyone away, but if, we've had folks that just show up and we're not going to turn folks away, we'll see them, but we're trying not to advertise that yet. At this point in time, so we're really focusing, and we would encourage you to encourage folks to access us through one of those referral sources. That would be the police, that would be the Wood County Hospital. It might be a local provider. Barbara, a private practitioner, should have access to that CSU number here real soon. But the Wood County Crisis Line is really the best way to funnel folks in, just so that we can control the flow. The worst thing that we could have, we might have, I think Jenna told me they had 5 or 6 admissions all at one time. You have one clinician to do all that, and it takes time to get people in. We really don't want folks sitting there waiting. It's just a bad customer experience. And if you're in mental health crisis, you don't want to wait hours to talk to somebody, right? So we do want to control that flow. We have the ability to control that flow if we send people through that Wood County Crisis Line. So hopefully that answers that question. And there was one other thing that I want to make sure, because it sounds like there was some confusion about who funds who and how everything's. So if you think about a spoke in the middle, you put any mental health agency, you just put Unison in the middle, and then there's these spokes, right? And out of these spokes, how are we funded? We're funded by Medicaid, by private insurance. The mental health board here in Wood County also subsidizes. And when Jen talks about the board, she's actually talking about the Wood County Mental Health Board. It's the Adams Board, but we just call it the Mental Health Board for short. And essentially that board is so important, and they do such amazing work here in Wood County. They have made it so that money is not a barrier to treatment. If you need treatment, if you need medication, and we try all those other avenues, insurance falls through, they're unable to make a copay, they do have funds and they will pick up the tab. We've seen it over and over again, that should never be a barrier. Somebody saying I can't afford it should not be a barrier to access help in Wood County for mental health services, because the board picks the mental health board picks that piece up. So I don't know if that helps if you think about how Unison is funded, and really any mental health agency in Wood County that's a nonprofit is funded that same way. You have all these different spokes. And so we fall under the Wood County umbrella, the Wood County Mental Health Board's umbrella, and they help fund various programs, the CSU being, they're a big funder of that, in addition to grants and other ways of funding that program. So hopefully, I don't know if that's helpful or not, because it seemed like there was some confusion, like who runs this, how does this all work? Hopefully that explains it a little bit more. And if not, I know we're supposed to wrap up here in the next 5 minutes. We can stick around. I'd be more than happy to answer any questions about that if I can help out.
This isn't about that question.
Sure, absolutely.
I'm assuming this only relates to adults, 18 and up.
Yes.
No children, we don't have any programs.
We do a little bit of outpatient therapy and such, so Children's Resource Center has their residential unit for kids, which is similar yet different, but that's the only thing for kids in Wood County. I know that there is hope down the road that one of the providers will provide something similar for kids.
And it's only for people who live in Wood County.
Primarily, so there is some work on the back end for potential out of county placements. So that is a situation between the board, and they aren't looking at that until we get open to full capacity. I know like Henry County, some of the outlying areas that don't necessarily have a facility want to work out a situation with the board that they could fund someone through their, so we're watching that. Again, we've had it, like we had somebody passing through, like they got pulled over by the State Highway Patrol that was like from Cleveland, and they were going to be admitted. We got that approved with the board because they were here, so we're also watching, because we don't want it to be a situation when we're open full capacity that we're full of folks that are not from Wood County, because that's not. So it might be like a limited, like one bed that can be on county. So
You said there was one of your.
we apply for Michigan. We have one. We're just Lucas County and Wood County.
But I thought you said there was, you said there was one of those programs in Michigan.
If I did, that was a misspeak.
She did.
We're modeled, our CSU is modeled after a CSU in Michigan.
Yeah, there's,
I'm not sure.
like up in, it's like Saginaw, it's way up in Michigan. That was just I wasn't here at the time. It was now the Wood County Mental Health Board. She's the ED executive director now. They went up and visited and kind of looked at that model. It's one that's in a lot of the research on the patient, but it was one of the, I think it was one of the first ones in the country. The name is escaping me. Sorry about that.
I have a bit of a personal question. So one of my diagnoses is panic disorder. So I tend to get, pretty bad panic attacks. So in those instances, say I'm home alone or something, and it's just running away from me, I'd be able to call the police and they'll potentially sit in one of those like 23-hour chairs.
For sure, you could certainly start with the Hope Line, like
Oh,
and
the
talk
Hope
to
Line,
somebody.
yeah.
But then you could absolutely say, help. And then what they would do is likely reach out to us and have mobile would come talk with you, and then kind of figure the best case from there. But there will be a point, and again, we'll get that. I think once that word gets out, I know the police are chomping at the bit for walk-ins and police drop-offs every time I see them. So I think that when that goes out, then you'll be able to walk in. I mean, I think our plan will be, the tentative plan is to initiate the drop-offs with BGSU and BGPD. They're probably our two biggest referral sources. I mean, as far as the law enforcement, we'd start there, we'd get the bugs worked out, and then allow walk-ins for the community, because I think that is, that takes the stigma away too. So that is, my ultimate, the sooner the better. Like I said, Katie Frank, who is kind of my partner, she's technically the director of the unit. She's the nursing side, so we bring in the nursing side, and then I'm more on the therapy social work side. I know we are both ready to do that, but as I was talking earlier, we also want to keep all of our staff. So we have to kind of find the balance. So it's manned by a company out of Texas. So what happens is all the way around the clock protocol, they basically basically triage for us. So if you call the Hope line, it's a licensed clinician, because that we just weren't. It's just, they're one of the biggest providers in the country for, yeah, it's just a big company out there that does that. Yeah, they do. Yeah, so they do, but then they have, and like the police, folks when, or like providers have a direct line to us that they can bypass taxes. So when BGPD gets a call and they think they need us, they have a direct line. Yeah, we just, because the volume and like, so part of my workload is I get a log of all the calls from protocol. So we might get like 20 a day that they'll talk with somebody on the Hope line, but of those 20 a day, maybe 2 of them, somebody was just saying, I just want to talk with someone. Not that we can't do that locally, but that we just can't staff that. So then that decision, like I said, protocol kind of does the triage process. Protocol. Mm-hmm. Yeah.
Okay, just 1 second, please, before you go. Yeah, Jackie. Okay. Jim, that was absolutely wonderful. I think it was clear that everybody thoroughly enjoyed it. It's so comforting to know that people with your expertise and your commitment are here to take care of us, because we really count on you, and you make a big difference in people's lives. So thank you so much for what you did. You also handled the technology crisis well. That's a certain amount of, so thank you for doing that. Again, if you would please take your cups to the counter over there and turn your name tags in. There's a bag out in the hall where you drop your name tags. And have a wonderful weekend. You get ready for the snow on Monday. Thank you.